on the exam that was miskeyed. So some of you may have taken the exam, and it will be corrected. Some of you may not have taken it before it was corrected. So from that standpoint, is just be aware of that. And also, there is another question that is under consideration, if you will, because of the way it's worded. Most likely, it'll be thrown out. But since some people haven't taken the exam, I'll won't go into it any further than that. So just to let you guys know, anytime, and I think you guys know this, you've been pretty good with regard to doing this, is that anytime that you have a question on the Maribel, I don't know which one, the number specifically off the top of my head, but your grid, if it was miskeyed, most of you got the right answer, but got the question wrong because it was miskeyed. And then there is another question which came about, which I can't go into much detail with, dealing with a black box warning. I'll just put it that way, which I'm correcting on that one too. But your grades, if you miss those, yeah, you should be notified that it would come up. But, you know, there is sometimes when I'm writing these questions and I look at them is I try to write the questions and I try to set them aside for a little bit and look back over them before I send them to Aiden. But there is every now and then ones that I'll mess up, or sometimes I'll pick up that there is an issue with regard to it. So if you ever have a question, I'll be glad, you know, send me an email. I'll be more than happy to either explain why the answer in my thought process was there, or I will, you know, look at the question and see. And sometimes I wait to see how everybody is done and then decide whether we need to throw out the question. So, so moving on today, today we're going to be talking about bipolar disorder. We're going to primarily talk about it today and into tomorrow, even though the way the schedule is set up, it should be bipolar today and drug interactions tomorrow. So we will cover drug interactions, but the bipolar will overgo just a little bit more. I will apologize to you guys ahead of time because I don't know if any of you have taken the new shingles shot, but I took the first one, the new shingles vaccine basically is a two shot combination. So I took the first one, and probably about 24 hours or so, it was literally that flu type situation. I felt like I was coming down with the flu, and everybody went, so, you know, don't worry about the second one. It's not going to be as bad. Well, it wasn't quite as bad. I haven't been the intensity, but you can hear my voice is a little raspy, and so I may be going a little bit slow today. So Jason, my wife what happened with her is reason she's got put on is because she did get shingles last year, and basically, or the year before, and that she was actually in a priority group to get it, people that had shingles. But the new vaccine is better. But I will tell you two things is, and I've talked to a number of people, it is your arm will be sore typically for 2 days, if not 3. I had mine on, let's see, my wife had hers on Thursday, and she still had it. She actually woke up in, let's see, about 18 hours. Typically, these symptoms hit about 18 hours. Talking to some of the people that were given the immunizations, they said a lot of people felt bad, and so they didn't come back to get the second shot, which is not good. So, Eddie, the thing is the push-ups don't, because I was supposed to be working out with Krav, and it's like I can still do the push-ups, but it really is just one of those things where it has a situation of I can't do as many. The muscles go out quite a bit, but actually working and moving around will help it move around there. Rebecca, you were saying about the pharmacy. It's I don't know if I told you this, but one of my wife's friends was under the impression that with flu shots and shingle shots and so forth is that she could get them at the hospital, but she said the hospitals always get the leftovers. And her perception was that you went out to, you know, the county surrounding the hospital because you could get the fresher vaccine. Um, and that the hospitals just used what was left over for the older vaccines, which I had to say there is no basis for that whatsoever. But Rebecca, you said the pharmacy that's exactly what happened. Is I called around and found 2 pharmacies that did have the vaccine, but there is a wait list. There was a wait list for several. Now the interesting thing is, sometimes is almost in this area, if I go to a pharmacy, it is usually one of my students that has to give me the shots, which is really funny. They are so nervous when they're starting to give the shot, and I get tickled a little bit with that. So some of you probably will run into that over the years. Okay. Yeah, actually, my wife is reading something is that the new vaccine is 60 years and older has a priority, and but and people ask me about this, and it's really what you're doing is you're actually stimulating your the older vaccine had about a 50% immunization. In other words, you had about a 50% chance of not getting the shingles if you were vaccinated, and the new dual shot is now I think there's a 90% effectiveness there. So we're going to be seeing a lot. And then the big thing here we've had at University of Georgia was we just got a $150 million grant, 120 or $150 million grant to develop new flu vaccines that are supposedly not going to, they're going to cover a wider range of the flu things there. So just a few things, catching up with that. And then the other big news that you guys just probably should be aware of if you're not is a lot of this stuff about vaping, these diseases, this lung disease. We've had a lot of I think there's about 18 deaths now. And so some of that has been traced back to where people are refilling the canisters. So if any of you are dealing with people that are vaping, be aware of that. They're developing popcorn lung. And I don't know if I mentioned it to you before, but the popcorn lung is not based upon the lung looks like popcorn when it gets diseased. It's based upon it was a particular condition that developed with people that were actually working at a popcorn factory that were using a sweetener. And that sweetener, basically, when they inhaled it, could create an issue. The other thing along those lines, this is sort of like the up-to-date in the pharmacology world or pharmaceutics world. The other thing with regard to vaping is a lot, as you know, several states have banned some of these flavorings and stuff. One of the things that emerged because of that was that a lot of people have used these flavorings in these e-cigarettes and vaping and so forth. And the companies that have been putting them out have been arguing, well, they're used in a lot of food products. They're perfectly safe. There's no problem. Well, what they forget is that the safety data was determined by oral ingestion. And there is an entirely different dynamics when somebody is inhaling those flavorings. So it's sort of an interesting thing where that individuals have pulled back on the issues of trying to use safety information based upon food products taken orally, and trying to use that as a basis for inhaling those products and still being safe. Then the last little thing, I don't know if you guys have heard the big thing about the acid reducer Zantac. Zantac has been recalled. It is producing, or basically, the information has been that Zantac is contaminated with a chemical, I think it's NDMA, nitrosamines, that can cause cancer. And some new data, it's not really new data because I found out that it was present in 2016. It turns out that the scare that everybody was talking about here is that there was a contamination. It's the same contaminant that we saw with the ACE inhibitors, lisinopril and losartan and so forth, the ARBs and ACE inhibitors that were pulled off the market. And those The contamination was felt to be due to introduced in the manufacturing process. Well, Zantac has got a little bit different scenario. Is that people first thought it was a contamination due to the manufacturing process, but there is some data, actually some papers out in 2016 that were demonstrating that Zantac um, um, actually is generating this carcinogenic product, that when it's broken down and metabolized, that it's doing that. So Carmen, with regard to your question, a lot of this stuff, if you sign up for MedWatch, you should be getting these recalls and FDA things, especially like with the Zantac and things like that. So the MedWatch is probably the best thing that you see. I've got a couple of other listservs. I'll look and see exactly what they are and see if I can, if you guys will remind me, I'll try to give you the name of those where I get some of that information there. But with stuff coming out and things like that, what I'm going to try to do is I try to bring some of this stuff into you, because although it may not be specifically what we're talking about, you will have patients, and you will potentially have patients that will be asking you about that. So that's sort of like the recent news that happened this week, and just sort of bring you up to date on that. So this week, yeah, the FDA website will send that out, and the MedWatch picks it up, but it also sends the label. So anyway, and they don't really, a lot of people worry about getting inundated with your email box getting full. If you're like mine, it fills up quickly. And and then when you sign up for these listservs, many people worry about, getting spammed, because I get a lot of spam. And I will tell you that if you go to unsubscribe, it just confirms your email. So my IT guy just says, if you're getting the spam, just basically delete it and move on, which is what I've learned to do. Okay, so this weekend, we're going to talk about bipolar. And what you're going to see is some of the drugs that we talked about last weekend we're going to see them too. So the big things that we'll introduce this time is the use of some of these mood stabilizers, which are these, several of them have anticonvulsant type actions. We'll talk about some drugs that have been used and may not have any efficacy. And then we will finish up tomorrow talking about drug interactions. Now, you guys have had drug interactions in general. We're going to talk about some and adverse drug interactions and go over a little bit more with that, which will be something that'll be, I think, particularly helpful to you. Okay. All right. So let's get started, and we're going to talk about these mood disorders, and with bipolar disease. The thing about it is, we find that there is, in my opinion, the general lay public is aware of bipolar disease. I think a large part of it was, if you guys will remember, a few years ago, Abilify did a big ad campaign. It's actually surprised me a little bit because I was wondering if these antipsychotic drugs, if there would ever be any public, direct consumer advertising. And Abilify did it with bipolar disease. And there's a couple of others that have gone about recently, specifically with bipolar disease. And there's one right now, forget which product it is. One of you may remember that it shows the woman, she's in a state of mania where she's buying all this stuff. And then after she's treated, then basically you see her packing all the stuff to go back. So we do see that it is estimations of affecting about 1 to 1.5% of the population. It was referred to as manic depressive disorder. And we often saw that in some of the older literature, they would say that the first episode usually occurred in the mid-20s. I think what we've seen is that probably the first episode could occur at a much younger time, but it may have been misdiagnosed. One of the big things that I want you to be aware of with bipolar disease, and sometimes this becomes a sort of an issue with the individuals that are that we're dealing with and people forget about is that we do see a potential high rate of suicide. Um, and talking to a couple of coroners, one of the things that is becoming difficult is with the opioid crisis. We do have some opioid deaths, which may be they really are saying that it's very difficult. That there was a headline that came out a year or so ago that basically said that the opioid crisis we've had, that the coroners can't keep up, and there's probably more opioid deaths, but they haven't been able to do autopsies. And the coroners also say, there's times when some of these deaths occur, and it could be an accidental overdose, but sometimes it could be could be suicide. But we do see a high rate of suicide, and it's something that we have to be aware of. Sometimes what we find is individuals, when they're seeing the manic stage, what we see is that they just dismiss that there could be that they don't think the person has bipolar. They think they've come out of a depressive state, and they just sort of drop their guard there. So, but I do want to, make sure that you guys know, and some of this stuff I know you've been practicing clinicians, and a lot of this stuff we give you is, we want to make sure clinicians give it, and a lot of times you're seeing similar slides as what I'm showing when I'm teaching these topics to physicians. Okay. A key point here, I didn't put it in highlight because I've highlighted a little bit later, is that a lot of times it is actually undiagnosed or misdiagnosed. And actually there's some studies done that suggest that this may have, that's an average of about 8 years. What we see is that also people have looked at when do patients commonly seek and, assistance following the first appearance of symptoms. Now, these types of studies are a little bit, you've got to recognize some of the limitations, because with these type of studies, one of the big things is you're retrospectively looking back to try to decide when these symptoms first appeared. But what you find is that patients may not come in for 8 years, or are not diagnosed for 8 years, an average of 8 years after the symptoms. And then it may be, another 2 years before they actually come in. Most of the time, they're going to come in when they're in the depressed state. Okay. Many people with the mania that occurs, they think they're out of it, or their caregivers or their peers will actually encourage them that they've seemed to snap out of it, not recognizing the issues that this may be a part of the disease that they're seeing. We do see a fairly large number of patients. I don't think I've seen some recent data on this. I think we probably have gotten a little better, but we do see a large number of these patients that are either untreated or suboptimally treated. One of the things that you might see is the patient may be looking to go to treatment in the depressed phase, and then if they cycle to mania, they think they've come out of it. We have seen a large number of patients that have been inappropriately treated. The biggest thing, which you'll hear me say multiple times this weekend, is this common scenario: someone shows up with depression, and they are just simply diagnosed as being depressed, and so they are simply put on an antidepressant. I have seen patients that have been put on the signs of depression or that they come in with a lot of time is tired, fatigued, sleeping a lot, and things like that. And I've seen them being put on stimulants. And of course, one of the big concerns we have with using an activating antidepressant or a stimulant is that you can actually cycle these individuals into a manic phase. I've even seen people that, sometimes what they present for in a case of, for example, the scenario of can't sleep, give them an they gave them, basically Ambien or something like that. I'm just curious from y'all's perspective, when you see patients that are misdiagnosed, what do you typically see them, put on? What have you seen bipolar patients? What kind of medications that would be considered basically due to misdiagnosis have you seen them on? Like I said, I've seen a lot of them on activating antidepressants. I've seen a lot of them on Effexor. Yep, stimulants and Effexor. If it's a younger person, a lot of times the ADHD meds go into place. But typically, it is either an antidepressant or a stimulant. Is what we typically see. Rebecca, you've seen benzos. I've seen a few of those with benzodiazepines that people have sometimes either are trying to, get them to calm down or help them sleep or things like that. So one of the things that you run into, and I've seen a lot of psychologists around here, talk to several over the years, that it's like, I've got a patient I'm seeing, their general practitioner has got them on the wrong meds because they think they're depressed. The patient is clearly, they're clearly bipolar, but the clinician or the physician, general practitioner, has not done a thorough investigation, not done a thorough diagnosis, and basically diagnosed them with that. Janelle, that's another issue that that comes into play there. That is that sometimes the low dose antipsychotic, sometimes the antipsychotic may actually, may potentially be a better choice than some of the other agents that they've used. What we do see, as you guys know, and again, I'm not want to spend a lot of time here on the basic diagnosis. This is something that you guys have got a lot of experience with. But we have seen a number of things, episodic mood disorders where we have mania, major depression. We can have mixed or hypomanic episodes. Probably over the years, the people that are in the mixed or the hypomanic episodes, especially the mixed episodes, have been some of the ones I've seen more difficulty with regard to treating. And so what we find is that sometimes it's really how they present to the clinician. And again, if they go to a GP, one of the big one of the big issues always comes up is, have they taken the time to actually develop or to do a complete diagnosis? So when you look at, this is a slide that I find very helpful with regard, especially sometimes explaining it to individuals that may not have a background, is one of the things I always when I talk to the students, and many times I'll be talking about, changes in or mood lability when I'm talking to the pharmacy students or some of the undergraduate, maybe graduate students, is talking to them when I talk about how drugs affect them. One of the things is I'll use here's this line here is like your baseline, and that throughout the day you're moving up and down. But I've also used this slide to help explain to people how that the mood can change during bipolar. So, if we start over here with mania, here the person has got a lot of energy, seems to be, really getting a lot of things done. Most people with mania, the biggest things that, a lot of people around them will sometimes, if they've been in depression, the people around them will say, well, I'm just so thankful they're not depressed anymore. They've got all this energy. A lot of people will tell you, if I had to pick a mental disorder, probably I would choose mania. But we all know some concerns with regard that can occur in mania, but sometimes people look at compared to being depressed. So with mania, we talk about a lot of energy. The mood is very, very elevated. And then we talk about their mood can go down and they can go to dysthymia. So they're depressed, but not deeply depressed. We can come up to what is called hypomania or sometimes hyperthymia, which is the mood is elevated above normal, but not all the way to the manic state. And then we can see depression and we can see hypomania. And then we may have a period where they're symptom free and then it can recycle. And so what you find is, I don't know what your experiences have been, but what we find both with the patient and with a lot of the caregivers and peers, especially in parents, a lot of them think as long as they are in this phase here, that's okay. One of the things we have to really, there's a couple of things we have to do, is one, we have to emphasize that this manic state does have some downsides to it, okay? But a lot of people are like, if they're up here, or even above the line, which is normal, then basically they either are cured, they are they've gotten better, they don't need to take their meds. Those are all things that sometimes are there. But what you do see is when they hit this stage down here, this depression, then people get worried and want to get them in. So one of the things we see with bipolar patients is a lot of bipolar patients are very difficult, very similar to patients with schizophrenia, is that basically what we see is that compliance is a big issue, okay? But a lot of times patients, as long as they're above the line there, so in some form of mania, then they think that they're okay or cured. And this is when they may not want to take their medication. And then we also see sometimes where that these cycles can change drastically as far as how quickly they cycle. So we do see these mood fluctuations, and so and sometimes this can be accentuated. So patients with bipolar disease basically can do things sometimes to keep them in mania. But when you look at it, is that we can see these mood fluctuations that may go from severe mania to severe depression. And what we see a lot of times is individuals, one of the reasons substance abuse is an issue is because these individuals are trying to self-medicate. The other thing that we run into is that you've got to realize that you want to make sure that sometimes these patients will change their medications to try to keep them, may take their medications, but still be taking some of theirs, but take a little bit more to try to get them out of it. So one of the big issues is having them understand how this disease fluctuates. And along that line, we want to also have a good understanding of how things are interacting and so forth. So we need to know, another thing we'll talk about. You remember last week we talked about certain herbs. So those herbs that may be activating herbs can quickly move these individuals into these type of manic states or even depressive states. Now, I don't know, how many of you have dealt with rapid cycling patients? Janelle, you have? Okay, most of you have. General impression with dealing with those patients? Yeah, okay. So basically what y'all are saying is, so you're seeing a patient that basically is pretty difficult. I noticed another thing is that you've got individuals that don't want their meds. And the other thing, um, the thing was that when you come in with these is that these individuals are very difficult. And one of the worst things that I find, I'm going to point out to, although several mentioned, Danielle mentioned about hard to find the correct meds. The problem is with these cycling patients is sometimes you give them a med and the med seems to be working and you sort of take this deep sigh. And then the next thing you know, they've gone to the other way. They've gone the other way. So these patients, they get frustrated. They want meds to work well. They get frustrated because the meds won't work. One of the things that we see a lot of times is these individuals, you see a lot of clinicians that keep swapping meds, which makes it very difficult. And the other thing that I saw with a lot of you have mentioned that these dealt with a lot of adolescents, teenagers. And Jason, you mentioned a good point here is basically that some of these individuals, when you talk about rapid cycling, it's funny when I've gone out and talked to different groups, especially school psychologists and stuff like that. There will be some that will tell you, I've got patients that, in fact, one lady was telling me, I swore this patient was doing drugs because he was cycling so much. And it wasn't. Turns out, I mean, they were, they had a lot of different things testing on this kid. And she goes, the thing is it's almost like he was taking uppers and downers, uppers and downers. And she said, it turns out he was just, he was very rapid cycling. And this gets back to one like you're talking about, Arnold, is they just could not get this kid stabilized. Of course, he was doing very poorly in school. He was creating all sorts of issues, or I should say all sorts of issues were occurring because of this. Teachers were frustrated. Teachers thought he was just defiant. The parents were frustrated. The parents swapped. Another thing you're going to get is parents will try to swap caregivers because it's like, you can't fix him, so I'm going to take him somewhere else. There's somebody else that can, and which makes it, I think, even rough on the patient there. So there is just a lot of things about these rapid cycling patients. I used to tell people from a treatment standpoint, sometimes clinicians would say, oh, this patient responded, with put them on an antidepressant. And it was like, oh, the person showed a great response in a week. I was just so happy. And my first thought was, you've got probably a rapid cycling. And that's what I've seen over the years is these patients that seem to respond, especially to antidepressants, very quickly, are going to be the hardest patients to usually manage. Typically, and again, with demographics there, we see more common in female. But here's two things we need to look at. Number one is several of these patients may be hypothyroid. And there is some data out there, I don't know if you guys have seen it, that talks about patients that may fall within the category of euthyroid, but their thyroid may be at the upper or lower range. And that by especially lower, the people that are lower range, that are borderline. I ran into this with the military, where the military doctor on one patient was basically saying, if they're within the normal range, we can't treat them. The same person was seeing a psychiatrist, and the psychiatrist was basically wanting to put them on thyroid medication, but the military wouldn't do it. So they ended up fighting a battle, and finally they ended up getting her on thyroid medication. And that is, once they got her thyroid adjusted a little bit, even though it was in the range of normal, it was there. But we do see hyperthyroid too. So sometimes hypothyroid can go to think of it, we got things going both ways. So although many of these that are rapid cycling are hypothyroid, what you might want to do is just use the term of there's thyroid dysfunction. So it's one of the things. And I'll see if I can find that literature, make myself a note on thyroid. But a couple of psychiatrists had told me that sometimes people get locked into the thyroid range. And by getting locked into that thyroid range, what happens is it's like, okay, the thyroid is normal. But by moving them just a little bit outside the range with treatment sometimes work. Another big thing is, I don't know about some of the patients that you've dealt with in these adolescents is may or may not, but a lot of times chronic illness is present too, which creates even a greater issue because these changes in moods can really exacerbate these chronic illnesses. Just think about if it's chronic pain. I mean, especially with kids, we can get patients that have arthritis that can be pretty painful for these kids. But we can have a number of other things. So, and then the fact that you've got a chronic illness, you've got them responding to the illness with regard to their mood. And for example, the depressed mood may actually make them feel worse. And then we have on top of it, we have the problem with individuals that are taking a lot of drugs for the chronic illness. So you got to worry about drug interactions. So that could be an issue too. But one of the things with this bipolar and this rapid cycling is sometimes people may not do a complete workup. I mean, you want to check and see make sure their thyroid is working correctly, their liver, their kidneys. You also probably want to check to see if they're anemic or if they have any blood issues going on. So these are all things that come into play there. speaking of kids too, the a lot of childhoods when it comes on is the often they have mixed episodes. One of the big problems with these mixed episodes, and I'm betting you guys, well, Janelle, you sort of touched on it too, is that this sometimes is just dismissed as just being a behavioral problem or some other issue like that. So from that perspective, what we have to do is we have to think about that sometimes we look at these individuals may have several episodes per day. When we call it childhood onset, it's usually before the age of 15. And again, as many of you have talked about, is many times they're more severe. Janelle, you are exactly correct. I mean, the situation is, in an ideal world, is that workup should be done prior to any meds. But just as you mentioned, is that getting those patients back in, because what happens is they will show up because of whatever's precipitating when somebody is rapid cycling. What can literally happen is that they move to a different part of the cycle and then they're not going to come back. Or they're wanting meds immediately and you're not giving them immediately, so they go find somebody else. So you're exactly right. And you guys are this is one of the things you're going to be fighting over and over. And sometimes trying to just have a frank discussion with them to explain to them that it's important that with their disease state that you get the right medication. That is what you're trying to do. But the point is that a lot of these people have either waited for a while to get there. And so as a result, they are wanting it results now. And then then you have to wait for them to come back. But meanwhile, they may have already done some work on looking up on the internet. They may have always have talked to some other people. And sometimes, when a child, the parents have already checked into that. So it's one of the issues. So Jason, one of the things that you will run into is the nice thing about your prescribing formulary is it's going to protect you a bit because you're not going to be able to. You will be able to prescribe for stimulants. So you're still going to get some of those drug seekers, but not the full gamut. And by the way, have you guys seen the stuff that's come out where that they, on the opiates, where they've actually, for example, I think they've done this in California, when somebody dies of an opiate, but move this mic a little closer. And what there some things if doctors have had certain number of people that have had they've died over opiates, as they've looked at them as criminal charge. Okay, I turned my mic up a little bit, see if that's better. Yeah, Carmen, that was one of the things is, in one sense, you look at somebody looking at your prescribing, and by the way, you guys, since you know this, I don't know if you know this or not, do you know that when you write prescriptions that's tracked pretty well? There is a lot of clinicians do not know this, but there is a company called IMS, which monitors, so that basically the drug companies purchase from IMS and pay a pretty big price for this, but they can actually, IMS can give them, exactly how many prescriptions you prescribe, you write for this. And this has come out in numerous trials with these drug companies over the years, where that they can identify and sometimes have even blackballed doctors that were not prescribing their drugs or were prescribing of competitors. And what we've seen, Janelle, as you're talking about here, is we've seen the states with all this stuff is they flag now. But even with like for antibiotics and things like that, is when you write a prescription, that can be tracked. And the drug companies get this information because they can find where that there is a high prescription of their competitors. They can do all sorts of analysis. We've actually tried to get some analysis. We've done some work with some of these analysis using some of this data, but the data that we're getting is the older data. The up-to-date data, which the drug companies want, is pretty expensive, and so, but that occurs. We've seen a lot of physicians, and medical residents and so forth, not be aware that they always wonder, how did the drug companies know to target them on certain things? They can pick up with to do that. So it's not the AMA that's doing it or anything like that. It's pretty much what the drug company will do is they will try to get people around them that are prescribing to get their patients to put pressure on the prescription on it. Sometimes there's been some very interesting things that have occurred. I have a friend who was testifying against a drug company, and he found they were going through his trash to see what he had thrown away. So it's sort of an interesting thing there. But, from a standpoint of what you need to be doing, I mean, what we saw was back when the diet litigation, there was actually maps of people showing which doctors prescribed weight loss products, which ones didn't. And they would really target, the ones that were doing a lot of prescribing, they would have a lot of reward systems for it. Now, we've cut back on a lot of what could be done with that, but that still did occur. Okay, big issue with this. We've touched on it a little bit, comorbid disorders. What we typically see as the comorbid conditions, we see a lot of anxiety disorders. We see a lot of eating disorders that are associated with this. So when we're dealing with these bipolar patients, just like we were dealing with patients with schizophrenia, is we have to take into account these comorbid conditions. Sometimes these comorbid conditions may have been diagnosed because of the symptoms may be similar, so what this comorbid condition may be. So for example, with an anxiety disorder, people like to prescribe benzodiazepines. So when you have a situation where that substance abuse is an issue, you can fuel that. So, and we do see a lot of substance abuse as a comorbid disorder. So typically we see, it's been estimated that there may be over 50% of bipolar patients may have a comorbid substance abuse. Now, sometimes this is hidden because in the past, sometimes these individuals having chronic diseases, let's say chronic pain, is that they may actually, people have ignored it because the individual may be getting a lot of opioids for the chronic pain and they actually have developed an opioid dependence. So when you see this substance abuse and this emerges, I've had seen personally where I've had students where it's been difficult for them to, somebody treats a substance abuse disorder and somebody else treats the other disorder. And we've seen where one of them will say, well, I'm not treating this till the other is being treated. So we get patients that sometimes get bounced around and we lose them. So, when we see substance abuse involved here, we're going to see increased symptoms because the drugs, when they're up, they're going to tend to be more manic. When they come down, they tend to be more depressed. So we're going to see increased symptoms. We're going to see increased drug interactions. So not only, today, since we have the prescription drug epidemic, that's a big issue. And we also see that the suicide rate is about doubled. So it's going to be important with regard to keep this in the back of your mind. Again, we had, when we talked about schizophrenia, we had a substance abuse disorder was a concern. And with bipolar, it's probably a little bit more of a concern. What we do see is there's been a number of studies, and we see that specifically with alcoholics and opiate addicts, we would see depression and dysthymia very commonly associated with it. And we also see a lot of stimulant addictions. And sometimes the stimulant addiction has been fed. It's been fed by the physicians. I talked to my students last week, and the thing about it is, I told them and even our former dean, he was like, well, how did the students get this? And I said, I don't know what your experience has been, but literally, I told our former dean here, I said, if I'm a college student, all I have to do is I have to I can probably find a physician that I'll walk in and say, look, I'm not doing well. I can't pay attention. Um, I had ADHD when I was little, and in college I'm struggling, and I can walk out of there with a prescription for ADHD medication. So nobody's going to check. I mean, especially me being away from home, nobody is going to necessarily call my pediatrician, who or I might even not remember who my pediatrician was. And I do see a lot of physicians that their description, or their discussion or diagnosis, I should say would be the best term, their diagnosis of ADHD is simply give them a stimulant and see if it works. I don't think that you would. I don't think any of you have not experienced that, if I'm not mistaken. And I do have people that have diagnosed ADHD that we have faculty that don't believe it. So there's still a lot of issues with regard to the ADHD medicines, but we really want to be careful with that. And sometimes we've seen, stimulants given to people that are depressed. So, and we know that's not it. All right, let's cover this slide, and then we're going to take our first break. So when we're in the manic stays, one of the things we have to rule out, this gets back to, I think, Janelle, what you mentioned before, is that you should really do the testing before you put them on drugs. So one of the things when a person, again, realize that they are more likely to show up for treatment in the depressive stage, but sometimes in the manic step phase, we may see them show up, it may come up. And so one of the things we have to look at is, are there other causes of mania? And so when you look at things, first of all, we know there are drugs that can produce manic states, stimulants, for example. We know that there are so one of the things may be looking at their medication history or looking at their current medications. We may pick up one of these drugs that is producing this manic type response. Now, when you're looking for those drugs, keep in mind some of these supplements may produce that also. So one of the things is, if you really see that, the mania started coming on, once he started taking this drug, that would be a good indication. We'll talk a little bit tomorrow about identifying how to know whether it's drug-induced and so forth. So drugs can do it. Sometimes the person may be bipolar, and certain drugs, like a stimulant, could move them more into the manic phase. We know that there are some neurological conditions, trauma, especially to the head. We know tumors, strokes, and, typically on a cerebrovascular accident or stroke, that we tend to think of as with much older people, but don't rule out that can occur. Like I have a secretary that is, in her, I think, late 30s, early 40s, who's already had a stroke. So there are young people that can have strokes. We also see there are young people that potentially may have used substance abuse, a stimulant, cocaine, meth, or something like that, that could cause a stroke. We have some young people that may have elevated blood pressure genetically. That can cause a stroke. Also, metabolic. We mentioned thyroid. You want to rule that out. Another thing would be potential B12 deficiency can cause it. And then another thing that people don't realize is infections. People can get, especially things like meningitis and things like that, can produce these type of things. Let's see. The tumors, actually, Carmen, that some of those have just been identified. They can be up in the frontal areas of the brain or the midbrain region, which can press sometimes trauma to the head. We can get bleeds that can press, or the bleeds can release into those things. So the tumors, primarily with this, we're going to see them in the mid portion of the brain to the upper brain. And Janelle, that is an issue, is that, we supposedly are being healthier, but we are seeing more people, younger people, that's being diagnosed with strokes. Part of this can be due to diet, can be due to some health issues that we used to not worry about until you were much older. And so that's a big issue that can occur. All right, so let's take our break, and we're going to come back and we'll start on some target symptoms of mania. So let's come back at 10 after the hour, and we will pick back up. Answer your question is basically when you get your question about cardiovascular accident in relationship to bipolar. Basically, it's dealing with brain injury. It's not really causing the bipolar. It may be causing a manic state. And let's see if I can go back here. I've got something here on my screen. I need to get off here. There you go. So it can create a manic state, and the cardiovascular. So it could be a stroke that would have involved the mid to frontal area, just like a tumor. A couple of things happen. Is one, it can simply be pressure. With a stroke, it could be it can be an ischemic response. So 85% of strokes are ischemic, which is a blockage of the blood vessels secondary usually to atherosclerosis, or it can be caused by a clot, an emboli that is thrown. If it is a ruptured blood vessel, then what can happen is that you get an increase in blood going into the cranial cavity, pushing down on the brain. And the other thing that happens is some of the constituents in blood can cause the neurons in the front part of the brain to fire. So it can produce that manic type effect. Okay. When we look at symptoms of mania, a lot of times, just like with most disease states, when the patient shows up, there are going to be specific signs and symptoms that are that flag. These are the things that this is what's bothering them. So some of these things we need to, try to focus those on. I mean, the patient is obviously there may be some other symptoms, and you're addressing the whole syndrome, but the patient could come back, and the patient is primarily looking at trying to address the symptoms. The background noise that you may be hearing now is Big Al decided he would, I told you guys before, there's something about when I lecture to you guys that it seems to stimulate two things in Big Al. One, his eating, and secondly, his sleeping. So his food has been sitting there all day, and he's decided that, hey, if I'm going to listen to this lecture, I'm going to eat. So hopefully it won't be too much. But so when you look at these symptoms of mania, things that they may be, addressing or seeing is irritability, maybe trying to be very manipulative. The mood disorder is very labile. One of the things that I'll point out to is over here is these hyperactivity things that you see, like sleep disturbance is a symptom that a lot of times they may just want addressed. For example, if they're sleeping too much or not sleeping enough, then give me something to do that. Some of the individuals will like these symptoms. For example, they might like the hypersexuality. Some people like the increased motor activity. They seem to be busy and can seem to be able to do everything. Have even seen people that like the fact that they can be more threatening or assaultive, that can give them some power. There can be some delusions. These usually are either sexual, persecutory, religious, or grandiose. And so one of the big things that you're really having to do is to try to find what's going on with these individuals. And, the medications that you choose, you're going to be looking to try to suppress the main symptoms that may be presenting to these patients. So for example, in this type of slide, notice it's in red up here at the top. Would just ask you a question that would say something like, which of the following signs are potential signs of mania? Okay, now we talked about this earlier, but it is such an important issue. That is why I bring it back up here, is that we have seen that there is a big misdiagnosis in bipolar. Um, probably the biggest misdiagnosis is right here, is because that's what they show up for. When they're manic, they don't show up. They feel like they're being energetic. They feel like they're getting a lot of things done. They have high energy, even though they may have some of these other signs and symptoms that may be more of an issue. But we do see problems with mania. You know, just like the commercial that is currently going on is depicting. One of the big things we do see is that these people can empty a bank account. They can buy a lot of extraneous type things. They can do a lot of excessive activities that could affect them or their loved ones significantly. Um, Even some of the aspects that they do can put them in harm's way. So things that we have to look at there. But what we saw is that since most people showed up with bipolar disease expressing as being depressed, we saw a lot of people that were misdiagnosed as basically unipolar depression and put on an SSRI. And so a lot of times, since that's what they present as, we find that they probably are put on antidepressants more frequently and at an earlier time than as antidepressants. The downside of that is we do see patients that when they are misdiagnosed and mistreated, um, given the wrong prescription, is that we see that there's studies that have demonstrated that over 20% of patients actually, by being put on an antidepressant, experienced either worsening or new rapid cycling following that antidepressant, especially if it's more of an activating antidepressant. And we also saw that a large number of children and adolescents that were originally diagnosed with depression. Think about it. Most of these kids coming in, if they're hyper and manic or something like that, they're really either diagnosed probably more with ADHD, or they are it's a behavioral response, and they may not get any treatment whatsoever. So what we find is that they may be originally, when they go into a depressed stage, that's when they get that's when they have their problems, and when they get taken in and somebody will treat them for the depression. So what we do see is that a significant number of kids or adolescents that were diagnosed with major depression actually develop mania or hypomania within 10 years after that original diagnosis, which suggests to us that they probably were bipolar to begin with. Now, here's the interesting thing, personal observation. So we saw these kids, and then Abilify put their ad out talking about bipolar. Suddenly, we started seeing, I mean, I would say that this is an ad campaign that looked like it had some benefit, because people suddenly started thinking, oh, let's move them to Abilify. And we got some patients who were originally thought to be antidepressed or be depressed on antidepressants were then moved to Abilify. And those patients were probably bipolar. But we did see an increase in diagnosis of bipolar after that Abilify um, ad campaign went on. So what we look for, and again, this is part of a workup that you guys do all the time. And the problem is, let me ask this, just from your estimate, a person comes into you showing depression. How long, time-wise, how much time do you think that it would take to determine, to basically work up this person to see if they were depressed or if it was something else? What do you think the amount of time would be? All right, so an hour, 90 minutes. Um, and I think that would be a conservative. I mean, basically, how many visits do you think it would take you? Okay, Janelle, you got 5. That's true, Carmen. The setting could have a big difference there from a number of things. I serve on the. All right, Janelle, you've been watching Shrek, okay? Um, okay, so clearly, clearly from your answers is basically it's going to be very difficult for someone to work up someone appropriately, a general practitioner in general. I mean, you're looking at the average appointment is 15 to 30 minutes. And part of that is that's not the clinician on there. It's interesting in the hospital records now. I start seeing this documentation of time where that the attending physician writes, I spent X number of minutes going over with this, this patient, so forth. So the thing about it is very difficult and think about it. You're also going to want, and working this up too, this is not counting for the fact that you are going to want some labs. That you're going to want some labs, one, to determine if something else is going on, and two, you want to know some labs because if you do want to prescribe, if you're going to prescribe to them, one of the things is basically an issue that you could go through. Maribel, I've seen that too, that is one thing people have used, the elevated expansive mood from there. So I don't think that would be unheard of from there. But the other thing too is, as a couple of people like a couple of you have mentioned here, is one is that question is, do we have a substance abuse issue? What other comorbidities do we have? So what we want to do is, one of the things is that I found with my students is that in today's generation we have people that mental illness has been more in the forefront with their grandparents and maybe even their great grandparents, whereas in my generation pretty much mental illness was you heard Uncle Joe was crazy, or basically you had somebody committed. Other than that, mental illness was really sort of not really talked about. So trying to get trying to get a good family history of that is very difficult. So one of the things is that you want to has there been a family history of mania? We look for typically an earlier age of onset, number of episodes. Many of you've talked about that. People have sometimes said weight gain or hypersomnia can also be something we see in these individuals. And so there's a lot of things that we want to get to do that. I'm just interesting, Kirsten, you said you had to do Rosarch with a rapid cycling patient. I bet that was an interesting, a very interesting episode there. So Maribel, the thing is, bipolar usually may present earlier. What we talked about earlier was that it's indicated onsets to 20s. Remember, one of the things that we find is with bipolar is that sometimes that it truly can present earlier, but a lot of times it may not show up in the 20s because really people dismiss. It really gets into that diagnosis. It really gets into the issue of where people think that earlier on it's being misdiagnosed. So, right, exactly. So when we look at these things, I mean, these are things we take into account. Okay. Now, we also see, as I said before, and I'm not asking, again, I don't want you guys to get caught up in, percentages. I'm not going to ask you what percent of bipolar patients attempt suicide. But what I do want you to know is that there's a significant number. It's estimated that about 25% are. With some of the things that we're seeing today with the overworking of the coroners and things like that, there's been a big debate as to whether some of these things were suicides. But what I do want you to know is this, is where does suicide, it doesn't mean that where we are more likely to see suicide risk is during the depressive stage. That probably doesn't surprise you. Then we see the mixed states, then we see the psychotic states, then we see the mania. So if I were to ask you a question like that, what you would look at is when they're depressed, they're more likely to produce they're like more suicide is more likely of an issue. But we can have suicides in mania. So if I were to ask you which, suicide has a greater risk in which state, the answer would be depression. But keep in mind, people sometimes um, forget that people can be suicidal in mania. One of the things that I always see is that when people are really, curious if you guys agree with me or not, but when I've seen really, really, really depressed patients, is a lot of times they're just almost unmotivated to commit suicide. Sometimes, with this whole thing about antidepressants increasing suicide, personally, I think sometimes what happens is we get them to feel a little bit better. To sometimes during that, getting them to feel a little bit better actually gets them to a state a little bit to the point where that they would be more likely to commit suicide. So I think that when we first start them on this, it's when we really have to watch out because a lot of times if they're really, patients that I've seen that are very, very severely depressed and talking to other people is that they pretty much um, they're not motivated to do anything. And Joy, you make a good point. Is basically um, when we discharge from the hospital or from any facility where they've been watched pretty closely. But again, if we discharge them, we've got them where that they have got enough energy and so forth. And so that's why we have to do it. But a lot of people go, "Oh, we got them taking their antidepressants. Okay, we have to worry about it." But I tell people, and I talk to counselors and stuff like this, is that it's really when they come in severely depressed, a lot of parents and so forth, caregivers think, I'm worried they're going to commit suicide. And I'm not as worried then as when they first start responding to treatment. And we've had 2 or 3 students that basically, it looks like they've responded to treatment and, everybody's like smiling. I'm still a little cautious. And yeah, sure. Next thing we know is we've got um, where they've attempted suicide or committed suicide. So a lot of times I'm telling people that when you use pharmacological agents and they seem to be responding, you're not out of the woods yet. A lot of people think we just got to get them where they're feeling good about themselves. But just as Joy, you stated, is that change in level of treatment is a risk factor. I really believe that. And that's one of the things that's been very difficult with all of these warnings on the antidepressants of the suicide risk. I honestly believe that with the drugs, the suicide risk comes from the slight elevation in mood to the state where that they can commit it, and it emphasizes why the therapy. Janelle, you hit a nail on the head right there, and so it comes to, and Carmen, that's a good point there too. So these are things that we just need to be aware of, and again, when you throw in substance abuse, that even is a greater risk there. Now, when you look at the course, I should have showed you that um, the ups and downs that occur in a slide earlier. One of the things we find is typically, the manic episodes usually are briefer. Okay, typically manic episodes are not going to last as long as the depressive episodes, but they stop pretty abruptly, and then they go into depressive. They usually go into a depressive episodes. One of the things, if you think about it, is that um, this big change is one of the reasons why a lot of people show up for treatment in depression. Because a lot of individuals, when they or people watching them when they were in the manic, they're a little crazy, but they're doing fine. Then they suddenly go depressed, and it seems to be a big abrupt behavior. You can look at different data, and that's why I don't have you memorize this, but I want you to just sort of be aware of it. And this is another reason I think that therapy is so important, because with a bipolar patient, you're looking at a lot of mood changes that occur, and a lot of times this is a lot for them to handle. It's also a big risk factor for them to, substance abuse and so forth. But what you see is that the average length of untreated manic episodes can be anywhere from 4 to 13 months. That can vary quite a bit depending on, now that we're seeing more people diagnosed with this, we could see some differences. We do see a lot of times that the episodes seem to be occurring at about the same time, or in the same season of each year. So that can give you some information which may be helpful in treating these patients, is knowing that they may be at a risk at a certain time, then you could be a little bit there. And there's been some evidence that they may cluster sometimes at 12-month intervals. So in women following pregnancy, if the manic episode occurs postpartum, we see increased recurrences during future postpartum episodes. So it's something, again, that we want to be aware of. In kids, a lot of people will have recognized that the mood becomes very labile before the bipolar actually comes on. Sometimes I think that lability of mood may actually be, not so much a prodromal, but maybe part of the disease. But again, as we've mentioned before, is especially in children, here's this lability of mood, very easy to be confused with ADHD. Even though with ADHD, but you could also include a number of other disorders, which may be behavioral disorders. Sometimes parents do not want to, when the lability of mood is occurring, it's just they're being kids. Some other people say, well, they're spoiled kids. So there's a lot of episodes there. Jason, you've got an interesting point there, because I have a friend whose son, child is exactly experiencing that. 6-year-old child, basically he's been homeschooled. Mother has doted a lot on him. He goes to one of these schools where they do sort of an interactive play group, and they just had a second child, and this 6-year-old has now become to the point where the mother's even made comments that she is afraid of him. He goes into his room, he tears up things, he has these rage episodes, and I've indirectly been asked about him from a standpoint of somebody has recommended that he be treated with CBD oil, and I know where that's coming from. And but my question has been: has this child been evaluated for bipolar disorder, for other conditions? And so the answer that I got was yes, but with probing a little bit more, the child has been diagnosed or been assessed by these individuals who run this interactive play group. So my recommendation is that I think it's very important that he be assessed. I would not put him on CBD oil. One of the people suggested put him on an ADHD drug, and so it is it's a big issue. I think there is a diagnosis that needs to be made with this child. And Jason, you mentioned a good point, is that temporal lobe epilepsy can sometimes can cause this. So the thing about it it scares me sometimes, is that it is one of the things that comes into play, where that many times especially in children and young adolescents, there is a big concern with whether these children are being diagnosed properly. I did find out about this one child there. He has not seen a licensed psychiatrist, and for the most part, I don't think he's even seen a general practitioner at this point for this particular condition. I mean, he's gotten his shots and so forth like that. But I do get a little bit concerned when we have a number of these with integrated play groups, which is, people have a little bit of child rearing background, but are suggesting and making medical diagnosis. Really, really be concerned. When the kids get older, one of the things we see is sometimes substance abuse. So I don't know what the youngest age you guys have seen. We've seen kids in the elementary school abusing drugs, huffing paint, drinking, 4th and 5th graders. I think the youngest one I've seen is 3rd graders. But in this particular child, I know there's no substance abuse. There's nothing he's getting into or anything else like that. But I do think, and I have suggested that they need to see somebody. And of course, the first response I got back, it's so difficult to make an appointment. And then also the issue about whether their insurance would cover. And, those are some barriers that come into. But especially when we get to in the adolescent ages, substance abuse could very well be an issue. Maribel, just so you know, after Big Al got his belly full, he is over in his bed snoring away, and you guys can't hear him. So when we look at morbidity and mortality overall, what we see is high rate, fairly good rate, almost 50% for alcohol abuse. One of the reasons is alcohol is very easy to get, even illegally. We see almost a high lifetime prevalence for drug abuse and dependence, which is about 41%. And it's not unusual to see somebody that has both alcohol and substance abuse. With prescription medications as easily obtained. I know they've been running an ad where that with regard to this, tobacco is a big issue. And in fact, someone asked me the other day isn't this stuff about vaping, doesn't this scare people? And the answer is no, because everybody, I talk to kids all the time, and vaping. They have moved to vaping and e-cigarettes, which under their perception, these are much safer. But one of the other things that we see, just follow up, Rebecca, is we see a lot of people, what happens is when they go into rehab is they shift from one abuse to smoking. So if you think about, Dr. Norton will talk to you about substance abuse and the dopamine reward center, but what you do is you swap one addiction for another. What we find is that during these episodes, during these bipolar, especially the mania, is they are self-medicating. So they have the substance abuse, which actually you've got this manic phase, and now you're putting on it impaired judgment, poor impulse control, and actually worsening of the condition. So the self-medicate to make them feel better may actually put them at a higher risk for other things. I'm very curious to see whether we're going to see if, as the different states have looked at the legalization of marijuana, what's going to emerge out of that. There's a lot of discussion because we just don't know. The other thing is I was up in South Carolina this week at a trial, and as I went across the state, billboards all over that are advertising CBD oil and kratom, or kratom, sometimes the way they pronounce it here. So talking to DEA, there's a big concern with that. These, one of the big things that we look at with these substance abuse as far as affecting morbidity, mortality, the bipolar, it can be a life-threatening because what you're looking at is you get a high risk of suicide. Estimates are that somewhere between 20 and 25% of the patients commit suicide, and somewhere between 25 to 50 have at least one attempt at suicide. See a lot of impact on these patients if they are not treated adequately. Even adequately treated, sometimes you're going to still run into this, but inadequately treated patients, we see a lot of impact on interpersonal relationships. All of the target symptoms that we see with mania can put a tremendous strain. We've seen, individuals that become hypersexual, that results in their relationships going south. We've seen financial, where the individual basically empties the bank account or runs up huge credit card debt. Career, we see a lot of absenteeism, a lot of things with regard to when they're manic, making decisions and doing things which are creating a problem. We've seen kids, I've seen it, we've had some of our students have to basically drop out, drop back a semester, sometimes withdraw from school. So these are all issues that occur. And then, especially with acute manic patients, A lot of times somebody needs to be potentially overseeing them or possibly put in the hospital because of this poor lack of judgment, which can cause a lot of issues. So, we see a lot of this where people are like, the one that everybody talks about is someone is up, can't sleep at night, stays on Amazon, and basically, has a lot of compulsive bias. We do see that patients, when they're adequately diagnosed, and a lot of them can function very well. I see the most stable patients typically are the ones that we have on medication and are getting counseling. Typically, when relapse occurs, it's due to medication noncompliance. They don't feel like they need it. The drug may not be making them feel good. Um, but a lot of times it's they feel like they either are cured or don't need the drug. We do see it's estimated up to about a third of bipolar patients um, only receive treatment. And part of that is because it's failure to recognize. We do still see in the South here a lot of this issues that when people go into depression, basically that is a moral character. And and we see when they're manic is that they're just crazy. Um, so, and then the other thing is for a long time, being bipolar was a stigma. You know, again, it's now being accepted more, but Joy, you make a good point is you're sitting with a young person, say in their 20s or a teenager, and basically explaining to them that we're not going to cure this disease. There's a lot of diseases that we can't cure. And it scares a lot of individuals because the idea is they don't want to be on meds the rest of their life. And so sometimes what happens is when they sort of get stabilized, they will go off their meds because they think they're cured and think you're just not doing this. I talked to a student this week that I don't know if I told you guys or not, but I may have told you. Um, Talked to a student this week that her one of her professors was it was a sociology class, I think it was, just started ranting and raving that mental illness was just a way of the government controlling us, and there was no such thing as mental illness. That I told that student that she needs to go and speak to that professor's department head, because I just thought about in a class of even only 40 or 50 kids, it could have been 100 and something. There's kids in there that are on psychopharmacological agents that need them. And when you have these type of people talking about that, doing that, it's just an excuse for that. Joy, that was the same thing I thought. I said, I told her, I said, well, from his discussion and he's having with you is that he just demonstrated that mental illness does still exist. But yeah, she said there was almost a whole lecture about that. In her lecture, it just went on that. And I did tell her, I said, you need to go talk to his department head. So it's just really crazy. Yeah, exactly, Jason. When they're mentally ill, it's so much easier to control them. Now, this thing you guys know, I put this in all my slides, and I try to put this. I always try to tell people I'm a pharmacologist, and as a pharmacologist, I actually look for ways of people not to be on drugs because I know that drugs are good, but drugs carry risk with them. I know drugs are expensive and so forth. So, um, remember last week when I was telling you guys about the combination drug that I told you about that the expensive was that trial was the one I actually went to and um, okay. So get this, out of $13,000 in medical bills, this individual for three drugs, which this individual took less than, there's literally three prescriptions, a little over three partial prescriptions. All right. So they took the drug for about a month and a half. So 1 month to, let's say 1 to 2 months worth of drugs. Of the medical bills of a total of $13,000, $8,000 was for those three drugs having having the prescription and one refill. $8,000. And basically, that's one of the things is, drugs are expensive. And that woman could have taken the same drugs taken as OTC products, which were readily available, would have been less than $100 for the same drugs. But anyway, fortunately the court saw that that was excessive and didn't approve those. But one of the things you find is, and this sometimes is difficulty, her insurance didn't pay for it. That was the whole thing. The insurance company said, we're not paying for it. And the insurance company refused to. That's why I went to court. So with bipolar disease, just like when we talked about with schizophrenia, and I am one of these people that it's not limited to these diseases, because you have chronic diseases and because these symptoms can recur, one of the things is that the patient needs to understand it, and the family, and I've got patient and family, but also any of the caregivers. Because the other thing that happens is sometimes you get the caregivers that they don't want to give these people drugs, especially if it's a younger person. I don't want my kid taking these drugs, or somebody has told me that we don't need it. And and get on the internet, and people come up with all sorts of different things. So one of the things is that, just as you were saying, is that it is important to have these conversations multiple times with the patient and the family and the caregivers. So we need them to understand that this disease is not being cured, that it can occur, that symptoms can recur, and we also need to know that certain things can worsen it, like stimulants and so forth. So we want to avoid things like that. The other thing we find is a lot of times you're dealing with, just like with substance abuse, guilt and shame come into play. A lot of patients after a manic episode, I don't know if any of you have seen this with some of your patients, patients may feel really ashamed at what they did, that they caused their family to go bankrupt, or they did something really strange that resulted in them being hospitalized or put in jail. They lack self-confidence, they'll question their judgment, and sometimes, unfortunately, on interpersonal relationships, the other person plays that against them. So there's a good example. Eddie was cheating on the partners that they cared about, same things like that. So a lot of times the counseling drugs not going to help this. Counseling is going to help this. They're going to worry, what if it happens again? And the other thing they also wonder, we also see is what happens. I got kids, what if my kids, or I'm thinking about having kids, what happens if these get transferred, So these are things that is part of that non-pharmacological therapy. Giving a patient a drug and just saying this will make you feel better doesn't address any of this. So one of the things we look at is we try to identify things that may be stressors in particular, not only psychosocial, but physical things that may precipitate the episodes. Where do we get that information? By getting good information from the patient or the family and so forth. What was happening when this occurs? Okay. What seemed to be the issue that's going on there? Teaching them to learn to simply cope with stress. That helps a lot of people in general. And Jason, you mentioned the other thing that people forget is not only does it show that when you use the pharmacological therapy combination, not only does it have better results consistently, but a lot of times we can use lower dosages of drugs. One is we are with that counseling, and this is one of the things that when people argue that you guys shouldn't prescribe, one of the big things I come back is you have got some of the best training to interact with patients and to find out specifically about side effects and how they're doing on drugs. You've learned to communicate with your patients. So we know we know whether the drug's working, and you will know also whether there's a side effect, and you can catch these things earlier. That's a big thing. So what we want to do is also teach the patient what are the things which should tell you that you may be, that mania or depression may be starting to come, and then give you a call. Okay. it's a big thing is why, you know, you're going to be taking these medicines. We're going to keep in touch with you. We're going to monitor you. We're going to try to minimize these side effects, and we're going to get you in treatment as soon as possible. We're going to make these changes so these things don't occur to the same extent there. Um, so Joy, your question is about certain meds given as PRN or adjusting them with different cycles. The biggest concern I have of that, the concern is, especially with something like lithium, my concern is that since it is such a narrow therapeutic range with lithium, I have more concerns about it. With regard to, I do see some clinicians that may make adjustments, but like doing PRN and some of these other things, I start getting concerned that someone is going to start making changes too quickly, but don't give it time to work. Something that
We have a little
because
voice
unless that
issue.
patient is all right, let's see if I can fix this. Is this any better? Testing, is this
Yes, I guess it's better.
okay? On top of my names to help a little bit, but it could be these connections here. The other thing it could be is that we could be getting a little bit of delay. But anytime that somebody is adjusting their adjusting these medicines, PRN, that the patient is doing that with lithium, I have a real concern with it. On some of the other drugs, I'm a little more comfortable with that, but my concern is that a patient is going to adjust the dosage or come off the drug too early, and then we see them a little bit further down. So I really have a concern with them with this. I mean, these drugs work, but a lot of them can have some significant side effects that we'll talk about. And I think, you know, it's just like with substance abuse or it's like, you know, take somebody that is got a headache I've got a pretty bad headache. Go take a couple of Tylenol. 30 minutes later, the headache's still there, so I'm going to take another couple of Tylenol. So that's the type of mindset that I worry about when patients are adjusting their dosage themselves, but a real concern when they're adjusting their lithium. Jason, we do see that in Europe they do still use a lot of lithium. Here we still see lithium used, but we've seen a lot more move to the mood stabilizers. I think one of the things is there are clinicians that are concerned about the person becoming toxic to them, and the other thing is that I think there's a tendency for us to move to the new drugs quicker, the newer and better drugs, when they may not necessarily be. People do well on lithium if they're monitored well, so the right patient does well. But we do see it probably used more in Europe. And I think in Europe, they may also have a few more preparations. We've cut back on the preparations that we've had with lithium. Right, new is always better because obviously we're paying, you know, we pay the extra money for that betterness. So let me cover this slide and we'll take our last break for the afternoon. So the predictors of suicide, what we see is people that seem to have a high degree of impulsivity, especially during that manic stage, people that are that have a substance abuse problem, people that have a history of childhood abuse, incorrect treatment. So in other words, not treating in manic, and then when people have the depression and the mixed episodes. So these are some of the things that we see that are common. When these characteristics are present, this is the ones we have to worry the most about with regard to suicide. But you should be watching for, should be monitoring for suicide and everything else there too. Okay. All right. So let's come back at 10 after, and we will go about another 30 minutes. Then you'll get your quiz, and we'll go from there. So,
Doctor, I'm going to also run the attendance poll right now.
Okay. Thanks, Aiden. talk a little bit about the mechanisms associated with bipolar. There has, again, with most of these disorders, people like to see if they can find a genetic component. And the idea here is with the genetic component, um, the idea is that it would help us understand it, but more so, I think that with identifying the genes, used to people would think, well, if you identify the genes, and the people could decide, whether they were at risk and so forth. But I think the main thing right now is people like to find the genetic component to see if they can identify where the molecular mechanism may be altered. So there hasn't been a single gene that's been identified with regard to bipolar. What we have seen is that there are several things, and this probably fits well with the success we've had with the different agents. So one thing is that the serotonin gene, transporter gene, may be altered, and that would be consistent with, the fact that we do see the depressive component there. And there have been a few alleles that have actually been identified. For example, the CAC-NA1C, sometimes referred to as the CACNA1C, or the 10M4, or the NCAN. Those people have said that there seems to be an issue there, but there's a sort of a small contribution. There's no doubt, even if there's a genetic disorder, we've known this for almost all diseases, that basically there's going to be environmental triggers. So it really is going to come down to that you have, if there's a genetic contribution, what you're going to have with that is going to be also an interaction with the environment, with stressors. So just like most diseases, this is a gene environmental interactive model. I think genetically we are programmed to be able to interact with the environment, and the variations and how people may express comes to what their genetic programming does to allow them to interact with it there. What I did want to try to cover a little bit before we broke for lunch is that there are several neurotransmitter theories, and a lot of these were based upon, some of the early stuff that was occurred. We know that with the depressive phase, for a long time, people have tried to identify serotonin, or have identified either norepinephrine or serotonin. I think Dr. Papp and Dr. Myers, have y'all had their class yet? Their depression class, where they talk about antidepressants? You haven't? Okay. Well, usually they're ahead of me. But one of the aspects, and I'm sure they'll go into greater detail, but one of the aspects with depression is, for a while, it was sort of interesting. Europe, United States, scientists were mainly focusing on norepinephrine, the idea that during depression that you have a reduction in norepinephrine, or there was a deficit in norepinephrine. In Europe, they were focusing on that there was a deficit of serotonin. So, what we do know is that, there's a couple of theories, which is basically, a lot of people would say there's an interrelation between the two, but we do know that in depression, there seems to be a deficit of norepinephrine and serotonin in the depressive phase. One of the things we do also is that during the manic phase, there seems to be an increase in norepinephrine. So really, they came up, you had people working at both of these. And again, I think Myers and Papp will cover this in more detail with you guys. But basically, the idea was that your serotonin levels were low in the manic phase and low in the depressive phase, and those then modulate the norepinephrine levels. And so they refer to this as the permissive serotonin hypothesis. The serotonin basically permits or adjusts the norepinephrine. So typically what you see is that most people think of the activated phase is due to elevated norepinephrine, and then the depressive phase is due to depression of serotonin, but also of norepinephrine. And this fits with some of the ways that we think our drugs work. So what people think, all right, so we in bipolar, what we have is we have a person's mood that goes from a switch from mania to depression. And in this switch may actually, what people have proposed or hypothesized is that this is due to changes in dopamine and norepinephrine. So sort of here's the theory. is when norepinephrine is decreased, we have depression. Dopamine activity predominates, and then we get mania or hypomania. This hyperdopaminergic activity may explain the hyperactivity and the psychosis associated with mania, sort of fitting in with what we talked about last week. So sometimes what we do is we explain how the drugs work. By explaining how the drugs work, we sort of back into how the disease may be acting. There's also the idea is that, especially during this mania, or during the that you look at, well, there's a heightened excitation and a decreased inhibition. So one theory that's been put in has been that there is a deficiency of GABA. So what GABA does is it normally inhibits norepinephrine and dopamine. Think of GABA as a inhibitory pathway. So the idea is GABA inhibits these, and what happens is that this seems to work because several drugs which are effective in mania actually seem to enhance GABA. So they seem to put the brakes on. There's also been some things which we won't go into, just mention them so that you've heard of them before, is that we've mentioned already that there may be either psychosocial or physical stressors that may trigger the episode. So what we think here is that basically there's a problem, a deficit or a problem with a particular pathway, and that these environmental factors, whether they're psychosocial or physical, activate those pathways, and that actually triggers the episodes. That's one of the reasons why trying to identify what the triggers are would help us quite a bit. And again, some of the triggers may actually be pharmacological, somebody using, a stimulant. And then some people have suggested that the central nervous system is just have this increased sensitivity. So certain things that occur cause this spontaneous response. And then another theory that's come in, and this fits in a little bit with some of the drugs we use, like lithium, is that that there may be some electrolyte disorders in the brain. And if you think about it, it sort of makes sense, because one of the things with the electrolyte disorders, what do electrolytes do? Electrolytes is going to affect the excitability of the neurons. So that these electrolyte fluxes may cause the emotional variations and the switches between expression of depression or mania in these particular patients. So when we look at it, let me go ahead and, let's go ahead and talk about it. So we've got neurotransmitters. Think about this also. Alterations in these electrolytes are going to affect the transmitters, so they're linked in there. When we look at it also, people have said, okay, maybe it is an alteration in the membrane or the secondary messenger theories. And so what happens is, if there's a problem or an abnormality, which could be genetic, in the membrane transport, we did identify that there may be a serotonin transport issue there. That basically these abnormalities or dysfunctions basically are a genetic vulnerability. That genetically you may have someone that is more sensitive to these effects there. So some evidence of that is we do know that in bipolar disorder, we see ATPase activity is reduced. Remember, ATPase is the enzyme that helps to keep homeostasis across the membrane. So the idea is, if the ATPase activity is reduced, what that does is it allows a secondary messenger to become active, and that can cause excessive release of transmitter. And in fact, there's some evidence that lithium may actually work this way. lithium actually block the synthesis of second messenger, which decreases the cellular responsiveness. So when these neurotransmitters stimulate the cell, most of these neurotransmitters activate a secondary messenger. So the idea is if that messenger is interfered with, that would interfere with transmitters. So when you look at all of these theories, so we've got transmitter, electrolyte, membrane, all of them really can be related. And the point would be is that technologically, can we even separate what they are? So we do know that there are some deficits, and there are several things that have explained it, and some validity to those drugs or to those theories have been given because that our drugs seem to interact with those systems, okay? When you look, one more thing is that we find that there are some changes that occur which sort of fit with our these seasonal or environmental things. What we find is that, and some people have suggested it's this environmental change, but ultimately this would get down to the neurotransmitter level too. So we do know that there may be some desynchronization that can occur. So people have changes in their sleep-wake cycle. There could be changes in the light-dark cycle. We know that people have responses to these phenomena.